My name is Christoph Saely. I'm a physician. I've specialized in both endocrinology and cardiology, and I'm working at Feldkirch, Austria. My talk considers the benefits and risks of antidiabetic treatment in patients with coronary artery disease and congestive heart failure. Diabetes is very strongly linked to an increased risk of coronary artery disease and also to an increased risk of heart failure. The problem actually also already begins at a stage of pre-diabetes, so also moderate elevations, for example, in post-challenge glucose, strongly predispose patients to increased cardiovascular risk. Of course, we wish to lower blood sugar in our diabetic patients, and this is clearly beneficial for their microvascular complications. So it's clear that if your blood sugar is lowered to an HbA1c of below 7%, then microvascular complications are largely prevented. However, the case on macrovascular diabetes complications is much less clear. So already the classical UKPDS trial did not show a benefit of glucose lowering on the incidence of macrovascular events. This is coronary heart disease-related events or ischemic strokes by more intensive glucose lowering. And more recently, the ACCORD, the ADVANCE, and the VIVIT trials did also not show a significant impact of aggressive glucose lowering on the incidence of cardiovascular events. Actually, in the ACCORD trial, the patient subgroup that was treated more aggressively had a higher overall mortality risk, which was carried by a higher incidence in fatal cardiovascular events. Indeed, if you lower blood sugar too aggressively, then hypoglycemia is one potential consequence, and hypoglycemia is strongly associated with an increased risk of cardiovascular events. There are established pathophysiological links between hypoglycemia and cardiovascular event risk, because hypoglycemia increases stress level, prolongs the action potential and QT time, and leads to calcium overload in the myocytes. This strongly increases the likelihood of arrhythmia and thus of sudden cardiac death, the most frequent, ultimately fatal consequence of coronary artery disease. So at the current time, we don't have strong evidence that glucose lowering lowers the risk of coronary artery disease. We should follow the ADA guideline that HbA1c should be below 7% in order to prevent microvascular events. Possibly on the very long term, also macrovascular events will be reduced by glucose lowering. We do have long-term follow-up data from the UKPDS or DCCT trials, which make such a link plausible. However, these are post hoc explanations. We don't really know about this. Now, another important question is whether specific antidiabetic drugs are more beneficial than others with regard to the incidence of macrovascular events or with regard to heart failure. Actually, evidence in this context is very poor. So insulin most likely has a neutral effect. The only randomized trial looking at the incidence of macrovascular events in patients treated with insulin versus non-insulin treated patients is the ORIGIN trial, which yielded an absolute null effect with regard to macrovascular events. Then sulfonylurea have no clear evidence of harm with regard to macrovascular events, but in observational studies they are associated with harm. There are no good randomized data on this issue. Perhaps metformin is of some benefit. However, also here the data are pretty weak. We have subgroup analysis from a subgroup of the UKPDS trial where benefit of metformin with regard to cardiovascular events appears likely. Perhaps the best evidence we do have is for pioglitazone. Pioglitazone in the PROACTIVE trial significantly reduced severe macrovascular events, and also in other trials, for example in the PERISCOPE trial and in the Chicago trial, pioglitazone when compared with sulfonylurea was more beneficial with regard to the progression of atherosclerosis. The substance is not safe with regard to congestive heart failure, so If patients already have congestive heart failure, we would not give pioglitazone. However, there are data that heart failure episodes which are triggered by pioglitazone are usually not fatal, and you would expect from real heart failure that it should lead to an increased risk of also fatal events. So it appears to be kind of a benign heart failure when you use pioglitazone and then develop swollen ankles or something. The newer substances, DPP-4 inhibitors, have been recently tested in 2 large trials, the EXAMINE and the SAVOR trial. Actually, there was a null effect with regard to the incidence of macrovascular events. There has been, in the SAVOR trial, a signal towards increased risk of heart failure with saxagliptin. However, this will need to be confirmed in future studies. For the time being, I think we can conclude that DPP-4 inhibitors are safe with regard to macrovascular disease, but do not provide any particular benefit with regard to macrovascular disease events.